Welcome dear students. In this video let us learn about the last type of audiometric test, that is impedance audiometry. It's very important. Impedance audiometry. Now the speciality about impedance audiometry is it is an objective test. Pure tone audiometry, speech audiometry, they are all subjective, but impedance audiometry is an objective test. I'll tell you the difference. In pure tone audiometry, you provide sound frequencies and the patient has to respond to you. If he hears or not hears, he has to let you know. If he hears, usually they raise their hand in pure tone audiometry. So you need cooperation from the side of the patient. Now the patient could be a malingerer, the patient could be mentally retarded, the patient could be a small child who cannot follow your instructions and respond properly. These are all the problems with subjective tests. But an objective test does not need response from the side of the patient. That is the advantage of an objective test, and impedance audiometry is one such test. So there are two components in impedance audiometry. The first component is called as tympanometry. Tympanometry. Let us see what is tympanometry. It is based on the principle that when sound strikes the tympanic membrane, some amount of sound energy is reflected back and some amount of sound energy is absorbed. Now, how much is reflected and how much is absorbed depends upon the state of tympanic membrane. For example, a stiff tympanic membrane would absorb very little and reflect maximum, whereas a compliant tympanic membrane will absorb more and reflect less. So far so good. I hope this concept is clear. Some amount is reflected and some amount is absorbed. That depends on the state of tympanic membrane. This is the concept of tympanometry. So let us see how it is done. First, let me write this principle down. When sound strikes the tympanic membrane, some amount of sound is absorbed while some is reflected. A stiff tympanic membrane reflects more sound energy than a compliant tympanic membrane. Compliant tympanic membrane will absorb more and reflect less. So how we do this procedure is, we have to seal the external auditory canal and then bring about pressure changes in the external auditory canal and then measure the sound energy that is reflected. What is being absorbed we cannot measure, but what is being reflected we can measure those sound energies, those sound vibrations. So with this, we can identify the compliance or the stiffness of not only the tympanic membrane but also the entire tympano-ossicular system, because they are in continuation with each other. The malleus, the handle of malleus is embedded in the tympanic membrane. They are all continuous with each other. So we can assess the compliance or stiffness of the entire tympano-ossicular chain with this procedure. This indirectly means that we are assessing the status of middle ear. Tympano-ossicular system is very much in the middle ear. So we are assessing whether the middle ear is healthy or it is diseased. So tympanometry is actually assessing the state of middle ear. So how do we perform this? We take a probe that nicely fits into the external auditory canal. The external auditory canal has to be sealed. So this probe has to completely fit into the size of the patient's external auditory canal. And the probe has 3 channels. We take a probe with 3 channels. Why do you need 3 channels? One channel is to bring about pressure changes in the external auditory canal, to cause pressure changes in the external auditory canal. The second probe is to deliver the sound waves. We deliver a single tone of 256 Hz. The second channel is to deliver a tone of 256 Hz. And the third channel is to pick up the reflected sound waves. The tympanic membrane absorbs some energy and it reflects some energy. So this third channel will pick up the reflected sound waves by a microphone. So these are the 3 channels that are present in the probe, and we put this probe into the external auditory canal of the patient. And now we bring about pressure changes from negative to positive, and we plot the reflected waves on a graph, and this charting is called as tympanogram. The chart that we obtain, the graph that we obtain is called as tympanogram. So on a tympanogram, on one side you have the reflected sound energy, and on the other side you have the pressure changes. At what pressure, how much sound is being reflected. That is our concept. So let me show you how a tympanogram looks and what are the various waves in a tympanogram. This is how a tympanogram looks, and I have already drawn various waves. I will explain what they are now. So on the x-axis you have various pressure levels. It is progressing from negative to positive. And on the y-axis we have the compliance. That is, this reflected waves are being plotted here, which shows the compliance. And you have various types of waves. And the first wave that we have to see is the type A wave, which is the normal wave. This is the wave that I am drawing now. The A wave is a normal tympanogram. That is, it attains its peak. There is maximum compliance at 0 pressure. Before that, in negative pressure, the compliance is low and it gradually increases at 0, and again in positive pressure the compliance gradually falls. This is a normal wave. There is another type of wave. I repeat, there is another type of tympanogram called as the AS type. This is the AS type. What is the difference between A and AS? In AS type, it is following the same pattern, but the compliance is lower. It is shorter than the normal A type graph. At normal or ambient air temperature, this is low. And when is low compliance seen? When there is stiffness of the tympanic membrane or there is fixation of the ossicular chain. When does that occur? In otosclerosis. Let us also write the interpretation of these graphs simultaneously. An A type is seen in normal people. It is a normal tympanogram. AS type is in the same pattern, but it is slightly shorter. That means less compliance. When will less compliance be there? When the tympano-ossicular system is stiff, that is, in fixation of ossicles. When will the ossicles be fixed? Classical example is otosclerosis or malleus fixation. Yes? Okay. The next type of graph is AD type of graph, this one. Here the compliance is very high. It is more than normal. High compliance is seen where at zero pressure, that means at normal ambient pressure, the compliance is very high. When will the compliance be very high? When there is ossicular discontinuity. The tympanic membrane is very compliant. Why? Because it is thin and lax. A thin and lax tympanic membrane would show high compliance. It would absorb all the sound energy. The compliance is high. So in AD type of graph, it is seen in ossicular discontinuity. When the ossicles are not continuous with each other also, there is no resistance. Say if the incus is not attached to the stapes, it is hanging loosely in the middle ear. All the tympanic membrane vibrations are transmitted to malleus and then to incus and then freely into the middle ear. It's hanging, so there is no resistance. This automatically increases the compliance. So ossicular discontinuity is one cause for an AD type of graph, and also a thin and lax tympanic membrane. A thin and lax tympanic membrane would also show high compliance. Next graph that we see, these are the three A type of graphs, A, AD and AS. All three are showing a similar pattern. Something is happening at normal ambient temperature. A is normal compliance, AS is lesser compliance, shorter compliance, AD is D for discontinuity of ossicles, a higher compliance. All at, but the pattern is same. At negative pressure the compliance is low and it gradually increases as we move towards zero pressure, ambient pressure, and again the compliance falls. These three are A type graphs. Next let us move on to the B type graph. In B type graph it is just a flat or a dome shaped graph. There is no change in compliance with pressure change, very little change. Even if you increase the pressure, negative pressure, positive pressure, whatever it is, the graph is more or less same. The compliance is not changing with pressure. When will the compliance not change with pressure? When the tympanic membrane is very thick or when there is fluid in the middle ear. When there is fluid in the middle ear, whatever you do from outside, there won't be much change because the fluid does not allow these pressure changes to be transmitted to it. So, a B type graph is observed, which is a flat or dome shaped graph. Flat or dome shaped graph. When is this observed? When there is no change in compliance, that is, fluid in the middle ear or a thick tympanic membrane. In these two situations, a type B type of graph is observed. Then we have something called a C type graph. This is a C type graph. What is the feature of the C type graph? It is attaining its peak. Maximum compliance is seen at minus pressure. In C type graph, you see the maximum compliance is attained at minus 200. A type graph is attaining at normal ambient pressure. This is attaining at a negative pressure. What happens when you apply negative pressure in the external auditory canal? The tympanic membrane is pulled outside. Negative pressure is like vacuum. It sucks everything. It pulls. So the tympanic membrane is pulled outside. In that situation only you will see maximum compliance in negative pressure. When does this happen? It is seen when the tympanic membrane is retracted and there is some fluid in the middle ear. So the tympanic membrane is retracted and when you apply negative pressure, it has come to its normal position and then it shows maximum compliance at negative pressure. Again, as you increase the pressure to 0 to ambient pressure and make it positive, the tympanic membrane is pushed back inside and compliance is reduced again. So initially the tympanic membrane is inside, it is retracted. When you apply negative pressure, it comes to its normal position, and so there is maximum compliance at that position where negative pressure. That is a type C graph. What is a type C graph? Maximum compliance at negative pressure. When is this seen? In a retracted tympanic membrane, which may show some fluid in the middle ear. These are the various types of tympanograms that can occur. And this is one of the most important concepts in an exam. It's frequently tested, be it an entrance exam or in regular board exams. So with a tympanogram, we can find out the compliance of the tympano-ossicular system. There is one more use of tympanogram, and that is to test the Eustachian tube function. For that also we can use tympanometry to test the function of Eustachian tube. How can we test the function of Eustachian tube with tympanometry? So, a negative pressure or a positive pressure is created in the middle ear by causing pressure changes via this probe. And then we ask the patient to swallow 5 times in 20 seconds. And then we measure pressure again. So, the job of Eustachian tube is to equalize the pressure in the middle ear. So, we have created some pressure, either a positive pressure or a negative pressure, and then we ask the patient to swallow. That will open up the Eustachian tube. And now the Eustachian tube should be able to equalize the pressure. If it is able to equalize, it indicates a normal function. And if it cannot equalize the pressure, that means the Eustachian tube is not functioning properly. Now the same concept can be used to check the patency of a grommet that is inserted in the tympanic membrane in a case of serous otitis media. Sometimes when there is excess of fluid in the middle ear, what we do is we make an incision in the tympanic membrane and we put a tube called as grommet tube. And we keep draining the fluid via the tube. But sometimes the tube itself can get clogged. So you should know whether that tube is patent or not. And that also can be checked by tympanometry with the same principle. Okay. So how do we test the Eustachian tube function? A negative or a positive pressure is created in the middle ear. And then the patient is asked to swallow. Patient is asked to swallow for 5 times in 20 seconds. This will open the Eustachian tube. Okay. Then the ability to equilibrate the pressure will indicate a normal tubal function. Pressure has to be equilibrated by the Eustachian tube. This indicates a normal tube. If it fails to equalize the pressure, it is not functioning properly. This is part 1 of impedance audiometry, where we are measuring the compliance of the tympanic membrane. This is called as tympanometry. The second part of impedance audiometry is called as acoustic reflex. What is acoustic reflex? When a loud sound hits the ear, say about 70 to 100 decibels above the threshold, then there is contraction of the stapedius muscle. It will pull the stapes laterally and that will dampen the sound. This mechanism is done to protect the inner ear from harmful loud noises. We call this the stapedial reflex. This is the function of the stapedius muscle that is present in the middle ear. It runs from posterior to anterior direction. It originates from the pyramid present on the posterior wall and it inserts onto the neck of the stapes. And whenever there is a loud sound, the stapedius muscle contracts and it pulls the stapes posteriorly so that there is dampening of the loud noise. We call this stapedial reflex. That is only acoustic reflex. Ipsilateral reflex, that is reflex on the same side, is first the eighth nerve. It is the vestibulocochlear nerve that hears and perceives sound, right? So first we have cranial nerve 8 that goes into the ventral cochlear nucleus. This eighth nerve synapses into dorsal and ventral cochlear nuclei, but for our acoustic reflex, ventral cochlear nucleus is important. From the ventral cochlear nucleus, the seventh cranial nerve is activated, the facial nerve is activated, and this supplies the ipsilateral stapedial muscle. This is the ipsilateral reflex. Let us see what happens in contralateral reflex. Now when one side sound is perceived, a loud noise is perceived, both the stapedius muscles contract. That is because there is some central connection between both ears. Let us see how that happens. Here also the cranial nerve 8 gets activated first and then the sound goes into ventral cochlear nucleus. From the ventral cochlear nucleus, what happens is, it goes to the opposite side medial superior olivary nucleus. Contralateral medial superior olivary nucleus. We have seen this in our auditory pathway. Eighth nerve, cochlear nucleus, then olivary nucleus, superior olivary nucleus. From the superior olivary nucleus, what happens is that opposite side facial nerve again, seventh cranial nerve, and from there the opposite side stapedius muscle, contralateral stapedius. The impulse is transmitted to the stapedius muscle of opposite side also. This is the mechanism of acoustic reflex. Now let us see how that is useful for us. This is about the acoustic reflex. And now let us see how acoustic reflex is useful for us. There are many uses with this simple test. They are: first use is that because it is objective in nature, it is used to find out the hearing in infants and young children. Hearing in infants and young children. And also, it can be used to find out malingerers. How? It was one of the tests to determine non-organic hearing loss also. A person who is malingering will claim that he is not able to hear, but when loud sound is picked up by the eighth nerve, the stapedius automatically contracts, and you can pick up the stapedial contractions and understand that the person is able to hear but he is feigning deafness. Third use is that It can detect a cochlear lesion, a cochlear pathology. How? Normally, stapedial reflex is present at the usual loud noise of 70 decibels and above. Normally, the stapedius reflex occurs at sounds equal to or above 70 decibels. But in a patient with cochlear pathology, this is seen at lower intensities only, at about 40 to 60 decibels. In a patient with cochlear lesion, this reflex is seen at 40 to 50 decibels only. It is seen at lower intensities. This is because of a phenomenon called as recruitment. We shall learn more about recruitment while understanding the difference between cochlear and retrocochlear lesions. But understand that in a person with cochlear pathology, at much lower intensities itself, the stapedial reflex will occur. And that's how we can make out that it is a cochlear pathology. Next, this simple test can also detect eighth nerve lesion. How can it detect eighth nerve lesion? When there is some problem with the vestibulocochlear nerve, if a sustained tone of some frequency, say 1000 Hz frequency, is delivered 10 decibels above the acoustic reflex threshold for a period of 10 seconds, the reflex amplitude will come down if there is some pathology with the eighth nerve. That is, the eighth nerve is showing some abnormal adaptation, and that is indicative of some pathology in the eighth nerve. We call it stapedial reflex delay. What is this? If there is eighth nerve lesion, it exhibits a phenomenon called as stapedial reflex decay. What does this mean? If a sustained tone of say 500 or 1000 Hz, it is given at 10 decibels above the acoustic reflex threshold. Say acoustic reflex threshold is 80 decibels and we are giving sound at 90 decibels for a period of 10 seconds. Now when it is well above the acoustic reflex threshold, what should the stapedius muscle do? It should contract, because the eighth nerve will sense it and send the signal. Stapedius will contract. But this eighth nerve, which is diseased, what it will do, if you send the same sustained tone for a period of more than 10 seconds, it will bring down the amplitude of the reflex to 50%. Reflex amplitude comes down by 50%. That is, the eighth nerve is showing abnormal adaptation. It is not supposed to adapt. It is supposed to sense this loud noise and send a signal to stapedius, but when you are giving the sustained tone 10 decibels above the threshold for a period of 10 seconds, what is happening is the stapedius is showing some abnormal adaptation and the reflex amplitude is coming down to 50% of the original value, and this is called as stapedial reflex decay. It's called stapedial reflex decay, and this is indicative of some pathology in the eighth nerve. Next, it can detect cochlear pathology. It can detect eighth nerve pathology. It can also detect some lesion in the seventh nerve also. Why? Even facial nerve is involved in the reflex arc. Eighth nerve, ventral cochlear nucleus. The efferent limb of the reflex is via the seventh nerve. So when there is some lesion in the 7th nerve, there will be absence of stapedial reflex, as simple as that. There is absence of stapedial reflex. But this is important to us when the hearing is normal and the reflex is absent. Now, stapedial reflex could be absent because there is some problem with the 8th nerve. There is no hearing, so there is no reflex. When the hearing is normal and there is no reflex, you can understand that there is some pathology in the 7th nerve. And also, where is the pathology? It is proximal. Now, 7th nerve, facial nerve, has a long course. If the stapedial reflex is absent, you can understand that the pathology is proximal to that part where the facial nerve is giving a branch to stapedius muscle. And also, this reflex can be used to find out the prognosis of facial paralysis. If at all the stapedial reflex reappears after a period of time, it indicates that the nerve is returning its function. Repeat, it indicates that there is a return of function of that nerve and a good prognosis is happening. We can find out the prognosis of the 7th nerve also. That is, if the stapedial reflex reappears after a period of time, it indicates that the nerve is healing and regenerating. Next, this reflex can also identify lesions of brain stem. How? Say, there is ipsilateral reflex but contralateral reflex is absent. That means there is some problem happening here. Pathology in the brain stem. In the area of crossing, some lesion is present. Presence of ipsilateral reflex and absence of contralateral reflex is suggestive of a brainstem pathology, brainstem lesion. So our simple acoustic reflex can give you so much of information. It can tell you whether there is problem in the 8th nerve, problem in the brainstem, problem in the 7th nerve. It's useful in malingerers, it's useful in infants and children, and it is also useful to identify cochlear versus retrocochlear pathology. Because in cochlear pathology, what happens? The stapedial reflex is occurring at a lower intensity. So these are the uses of acoustic reflex. With this, I complete the topic of impedance audiometry. The first part is tympanometry and the second part is acoustic reflex. The reflex can be measured. The stapedial muscle contraction can be picked up. And we can understand various pathologies based on this acoustic reflex. With this, I complete the types of audiometry. We have 4. Repeat, with this, I complete all the audiometric tests. We have pure tone audiometry. Next is speech audiometry, in which speech reception threshold and speech discrimination score both are found out. And third is Beckett's audiometry, which is outdated now. And finally, we have the most important impedance audiometry, which consists of tympanometry and acoustic reflex. The next part in assessment of hearing is certain special tests, about which we shall learn in further videos. So thank you very much and have a nice day.